I would like to thank the organizers for having given me this opportunity to do this presentation. It's a great honor to be part of this group of esteemed speakers, and especially I am honored to be doing this in the same dais as Professor Murali sir, who has been a teacher, mentor, and well-wisher for ages. And I'm also honored that one of my favorite students, Dilip Raman, is also presenting on this in the same meeting. So we've come a full circle. And my dear friend Ravi is also in the list of speakers. So it's overall, it's a great honor to be in this company of great speakers who I know and who I don't, who are, I'm sure, would have taught you a lot of crucial information about fever. I have a disclaimer in that I have not seen any of the presentations, so I don't know whether there's a bit of an overlap. So I would start my presentation with the disclaimer that I'm a pediatric rheumatologist, so my presentation will have a bit of a pediatric slant. I'm focusing my discussion on the clinical aspects of the conditions I'm going to discuss rather than the molecular aspects. One needs to keep in mind that these are incredibly rare conditions, and there are challenges in genetic diagnosis. And when you move from an Indian perspective, there are therapeutic challenges in the form of availability of some of the medications, affordability for general public, and how infections kind of change the landscape in terms of diagnosis and treatment. So I start with a simple explanation. What is officially described as fever? Well, NHS Choices, which is one which people follow in UK, defines fever as a temperature more than 38 degrees centigrade or 100.4 degree Fahrenheit. So a lot of people who talk about temperature have temperatures like 99.5 or 37.5, 37.6, like that, which in strict terms is not a fever, and we probably do not need to overreact to these. So once anybody is encountering a clinical situation of fever, there are three things that comes to our mind. One obvious thing is infection, common things first. This could be because of a cancer of any form, primary or secondary, neoplasia. And one thing that is not that often distinguished as a cause of fever is inflammation, which is what I'm going to focus on today. So, looking at the history of autoinflammation, which is the focus of discussion today, there has been description of intermittent fever with pain in various parts of the body in literature from as early as early 19th century. But the biggest landmark in the history of autoinflammatory disorder is the identification of the gene, the MEFV gene, which is responsible for familial Mediterranean fever. This was identified by the French cohort in 1997, and FMF, or familial Mediterranean fever, still remains the commonest and the earliest recognized periodic fever syndrome. The term autoinflammation was first coined in 1999. It appeared in an edition of the journal Cell, and they used that to describe a group of diseases characterized by recurrent episodes of fever and unprovoked systemic inflammation in the absence of guilty autoantibodies. So that is where they tried to make a distinction between autoinflammatory and autoimmune conditions. Since then, the spectrum has really expanded to involve a variety of both monogenic, that is inherited, and multifactorial inflammatory conditions, which are characterized by the dysregulation of the innate immune system in response to exogenous or endogenous stimuli. A lot of work in this area has been carried out by this person called Professor Dan Kastner and his team at NIH, he is regarded as the father of autoinflammation, who I've had the pleasure to meet during a recent conference. This is an increasingly evolving spectrum. So from about 3 or 4 named conditions, at the moment we have something around 58 autoinflammatory diseases who've all been discovered in the last decade or so. So before we go to autoinflammation, I would like to briefly touch upon the pathological mechanism or etiopathogenesis. Now, as you all know, our immune system has got two compartments. One is innate immune system, which we know is rapid, immediate, and non-specific, but has no memory. So any antigenic insult, the first line of defense is innate immunity, but that produces an auto-inflammatory storm. Whereas adaptive immunity is much more cleverer, smarter. So that is slower to evolve. It is very specific depending on the antigenic stimulus, and it has got clear immunological memory, means it reacts to certain stimuli from previous exposure experience. So this is the essential difference between innate and adaptive immunity. As I touched upon later, autoinflammatory diseases are a problem with uncontrolled inflammation due to a dysregulation of the innate immune system, not the adaptive immune system. This is in stark contrast with autoimmune diseases, which is a problem with the adaptive immunity. Now, there is also a big difference in terms of the cell types, the leukocytes involved here. It's usually macrophages and monocytes that lead the autoinflammatory diseases or innate immune system, whereas it is lymphocytes mainly which drive an autoimmune response, especially the B cell driven, CD19 driven in lymphocytes. There is also a difference in the key cytokines involved. It is essentially interleukin 1 which drive most of the autoinflammatory processes, whereas there are other interleukins like anti-TNF, interleukin 16, interleukin 17, interleukin 23, interleukin 8, so on and so forth, which drive autoimmune diseases. Why is this important? Because we often treat these conditions successfully by targeting the interleukins. So interleukin 1 therapy, anti-interleukin 1 therapy has become the mainstay in the management of autoinflammatory diseases. Talking about examples, there are a lot of monogenic periodic fever syndrome like FMF, TRAPS, HITS, etc. These are fancy names. I'll come to that later. There are non-hereditary conditions like Still's disease, which otherwise we call systemic onset JIA in children, and in adults we call adult onset Still's disease, and there are certain other rare conditions. There are a lot of metabolic conditions like type 2 diabetes and gout, which we now has got an underlying autoinflammatory pathology going on. So it may be interesting to see whether these conditions get targeted anti-IL-1 treatment in the future. Whereas adaptive immune response problems lead to autoimmune conditions like the ones we know, rheumatoid arthritis, Crohn's disease, psoriasis, psoriatic arthritis, lupus, ANCA-associated vasculitis, Sjogren's, etc. Now, there are autoimmune conditions which can cause PUO or which can present as pyrexia or name, unknown origin. Classical examples being lupus and ANCA-associated vasculitis, which we used to call Wegener's granulomatosis. So that is outside the purview of discussion today, so I'm not going to discuss further about autoimmune conditions and fever. So when does one suspect inherited autoinflammatory disorders? Age of onset is important. Most of the people who get these conditions have an onset maybe anywhere from infancy to young adulthood. If somebody in their late 50s or 60s present this condition, the chances are less. But however, there are new autoinflammatory conditions identified like Wechsler's and Schindler syndrome, which can be seen in older adults. There may be a family history. A negative family history does not exclude anything, but a positive family history is incredibly helpful. The characteristic presentation of these conditions is episodes of recurrent fever. And this fever is often associated with musculoskeletal symptoms like joint pain, muscle pain, sometimes arthritis, and a variety of skin rashes. Is this a post-infective syndrome? Sometimes you can get post-infective, most notably post-streptococcal syndrome, which can present with arthritis, fever, and rash. But the systemic inflammation, the level of systemic inflammation was too profound for this to be a post-infective process. We always need to consider malignancy. It could be a hematological malignancy, a lymphoreticular malignancy like lymphoma, or even a metastatic condition like neuroblastoma, which probably did not fit in for her age. And so we did a bone marrow, which was negative reaction from that. Now, she clearly had arthritis more than 6 weeks before her 16th birthday with no underlying cause, which would qualify her to be called JIA, or juvenile idiopathic arthritis, which is the bread and butter of rheumatologists across the world. So just a brief reminder of the classification of JIA. So it's essentially based on the number of joints, but there is one category called systemic onset JIA, or what used to be Still's disease, where significant systemic symptoms like fever, rashes, hepatosplenomegaly predominate the symptoms more than the joint symptoms. So these are the features. Anybody who has got fever, daily quotidian pattern of fever for more than 2 weeks, arthritis, plus any of the following, which is an evanescent erythematous rash, lymphadenopathy, hepatosplenomegaly, and serositis. She clearly had an arthritis, fever, and hepatosplenomegaly and rash, which means she met the criteria for systemic onset JIA, which is what we called her. However, in view of the ferritin, we were worried about one condition called HLH, hemophagocytosis lymphohistiocytosis. Now, HLH is a life-threatening complication which can either be a secondary to immunological problem like JIA or because of infections. So these are the diagnostic criteria for HLA. So either you need to have a molecular diagnosis for things which cause primary HLH, or you need to have these. So she clearly had fever, she had splenomegaly. You need cytopenia affecting 2 cell lines, but she only had anemia. The white cell count and platelets were actually on the higher side. So that didn't fit. The right usually are high and fibrinogen low. She did not have either. And the bone marrow did not show any evidence of erythrophagocytosis. She did have, however, very high ferritin and very high SCD25 levels. So she had 4 out of these criteria, not quite 5. And as I said, we were clear that this is not likely to be HLH because of the cytopenia mainly. And she was very well for that. She didn't have any neurological presentation, or she also did not have any coagulopathy. Despite not being in the right age for primary HLH, we did send a genetic screen for primary HLH, which too came back as normal. So with the diagnosis of systemic onset JIA, we started on steroids, IV steroids, and she had a spectacular response. After poor response to methotrexate, we had 2 options: to give her 4 weekly infusions of anti-IL-6 called tocilizumab, or daily injections of anakinra. She was very scared of daily injections and she wanted to go for 4 weekly infusions. So we started on tocilizumab, which we slowly spaced off from 2 weekly to 3 weekly to 4 weekly, and she had an excellent response. But 3 weeks after one of the infusions, she contacted us saying that she's having the same symptoms she had at the very onset: sore throat, earache, feeling tired, etc. So I asked her to get a blood test done by the local GP, which showed, interestingly, normal CRP, but low platelet count. The platelet count, which has always been high, dropped down to 80,000, and her ALT and AST were high too. So she had abnormal liver function. So I asked her to come to see us in the very same day. While she's on the way, she started spiking temperatures. Now, she is a patient who is immunocompromised, developing temperatures, and so we had to think about infections. We admitted her, and after blood cultures, we started broad-spectrum antibiotics. It was interesting to note that she did not have any features of flare of arthritis or rash, but her bloods showed HLH. She had a ferritin despite normal CRP and ESR. Her ferritin was over 15,000, and LDH and liver enzymes were massively elevated. Her fibrinogen this time was low and triglycerides were high, thereby confirming a diagnosis of HLH. Now, why is her ESR and CRP normal? We think that she's on tocilizumab, which is well known to spuriously suppress the inflammatory marker response. So if a patient is on tocilizumab, you cannot rely on the inflammatory markers to make a diagnosis. We did some more investigations. The bone marrow did not showed only occasional erythrophagocytes, which I think it's because when the result was phoned to me, we had to start her on treatment because this is a potentially life-threatening condition. So it was done after 2 doses of steroids, which is why it did mask the picture a little bit. An extensive infection screen was negative, although she was positive for Epstein-Barr virus PCR. Now, we know that EBV is one of the triggers for HLH. Management, we put her on IV methylprednisolone again, an excellent clinical response. While she developed this on anti-IL-6, because of that, she had no option but to go on to daily injections of anakinra, which switched off her inflammation like this in no time. So by a week, she was clinically and laboratory-wise completely back to normal. We still have one unanswered question. Was the cause of this HLH, or what we call macrophage activation in rheumatology terms, is that triggered by her systemic onset JIA, her Still's disease, or was it the EBV? My guess is it's probably a combination of the two. So, talking about HLH, which again is another cause of systemic inflammation. On the left side, you can see a lot of genetic conditions which can trigger a primary HLS. When it is because of other conditions, we call it secondary HLH, and one cause of which is infection, and EBV is notorious to do that. It can be because of malignancy, especially some lymphoreticular malignancies. So I recently had a call from an adult ITU about a 58-year-old person who had recently been diagnosed with lymphoma. He went on to HLH. So we tried to suppress inflammation with anti-IL-1, which is why my expertise was sought, and he actually responded very well. And it could also be because of autoimmune conditions like Still's disease, or inflammatory conditions like Still's disease. Now, a slide about systemic onset JIA. As I said, although this is a JIA with arthritis, often extra-articular features overshadow the joint inflammation. So you can get persistent fever, the rash, hepatosplenomegaly, lymphadenopathy, and even polycirrhositis like pleuritis, pericarditis, and peritonitis. We are always, all our patients with the diagnosed systemic onset GIA undergo a baseline chest X-ray and echocardiogram. As I said, the inflammatory markers are very high, ESR, CRP, and ferritin is exceptionally useful. These patients usually have leukocytosis and thrombocytosis, which is helpful to distinguish them from a hematological malignancy. Now, when these patients go into macrophage activation syndrome, the picture changes. The daily temperatures become unremitting continuous fever. They are more unwell. They often have neurological symptoms. They have coagulopathy, and they develop pancytopenia often, whereas you get the counts to be high because of inflammation. Treatment strategy, the first line in systemic onset GIA usually is IV methylprednisolone, and we start them on methotrexate, but quite often it doesn't work. If definitely it is between anti-IL-6 or anti-IL-1 treatment. The problem with anti-IL-6 is it does not completely prevent HLH or macrophage activation syndrome. So if these patients have HLH at the outset, the best treatment is anti-IL-1. The other treatments I've mentioned for completion's sake, but they are clearly not as effective. Now, there is an entity for adult physicians amongst the audience that there is an adult equivalent called adult onset Still's disease, which is again a multi-system inflammatory disease characterized by the triad of high spiking fevers, characteristic rash, and arthritis. Men and women are affected equally. However, there is a bimodal age distribution. There is one young peak between 15 and 25 years, which is why we think this young lady I discussed about, she probably has called adult onset Still's, because systemic onset GI in children is a disease of infancy and early childhood. So she probably had a adult onset Still's disease. And there is a later peak in the 30s and third and fourth decade. The main cytokine responsibilities are interleukin-1, and you get extremely raised inflammatory markers, and always, if you are suspicious, always check the ferritin. So these are the diagnostic criteria. There are quite a few diagnostic criteria for adult onset Still's disease. Yamaguchi is probably the most commonly used one. I'm not going into these details. You can find that from papers. So to summarize, the take-home message is in children and young adults, when they present with daily fevers, changing rashes, joint symptoms, raised inflammatory markers, always think of Still's disease. An incredibly useful investigation in somebody with PUO with that presentation is ferritin, which will often help you clinch the diagnosis. Obviously, this is with the disclaimer that you would have ruled out infections and malignancies. So, as I said, HLS in rheumatology is a potentially fatal serious complication. The commonest cause is systemic onset JIA and adult onset Still's disease. It can also be seen in other conditions. One recent cause or recent entrant this is MIS-C, which is multisystem inflammatory syndrome in children, associated with SARS-CoV-2. So some of these patients can present with HLS type of picture, which is why anti-IL-1 and anti-IL-6 were used in patients with these conditions. This is a preliminary diagnostic guideline for MAS, complicated systemic onset GIA. I'm not going into these details. It is extremely important to diagnose these conditions early and to intervene early. The mainstay for the management, the first line, is use of IV steroids. You can either go to a hematological route to manage these conditions where they use cyclosporin A, etoposide, and dexamethasone, but that is usually reserved for all the primary HLH. Or you can use anti-IL-1 if it's a rheumatological cause leading to HLH. But now we have expanded the spectrum that even patients with infection-induced HLH or malignancy-induced HLH are increasingly getting anti-IL-1 as a first line. Rituximab is another option if it is an infection-induced, especially EBV-induced HLH. Okay, so take-home messages. Please consider HLH in patients with high fever and without rheumatological patients, with or without rheumatological patients, with unremitting fever, cytopenias, neurological manifestations, coagulopathy. If you see a patient in intensive care setting or acute medical setting with these symptoms, and they are extremely unwell, always think about doing a ferritin level, which might again help you cleanse the diagnosis. But obviously, we need to look for underlying causes like infection and malignancy before we start immunosuppression. But it's important not to delay the treatment as well. Now we go to the other half of the discussion, which is periodic fever. Now, periodic fever, how do you differentiate periodic fever from any recurrent fever? Now, it is well known for children to get infections in the childhood, and in infancy, you can even get every infection a month, up to 10 or 12 infections. So when does a recurrent fever become a periodic fever? Obviously, when it's repeatedly happening. Secondly, when it's predictable. That's very important. Parents of children with periodic fever often tell that, I'm sure that he'll get it in 4 weeks' time. And they can predict when the next episode is going to happen. So when the interval is predictable, that supports a diagnosis of periodic fever. And thirdly, there is a stereotypy in these episodes. They have the same set of symptoms. It's always fever, sore throat, mouth ulcers, lymphadenopathy. And 4 weeks later, the same set of symptoms. If it's an infection, you will be upper respiratory infection, maybe a lower respiratory infection, maybe a skin infection, things like that. So the symptomatology can keep changing because of infection. Here, you get exactly the same set of symptoms with every episode. And the other thing is children are completely well in between. Now, why do we need to diagnose this or investigate or refer these patients? Firstly, to see whether they have got any inherited monogenic periodic fevers. And why is that? It can produce long-term life-limiting complications. It can affect their growth, it can affect their schooling, it can affect their development. But last but not the least, some of these conditions can lead to systemic amyloidosis, which can lead to renal failure. So some of the patients with chronic kidney disease in adults, when they have been picked up to have renal failure due to amyloidosis, when they have been asked, they said we were having recurrent fevers as a child. So that is something which, when the boat is completely missed. Now, differential diagnosis of periodic fever, it can be because of multifactorial inflammatory disease. And I would like to talk about one condition called PFAPA syndrome. Now, this is an acronym of periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis. It's called PFAPA syndrome. This is the commonest cause of periodic fever in childhood. And the etiology, it's still debate. We don't see any reason this happened, but there is a theory that this could be because of some incomplete mutations, or it could be an infective trigger. Usually episodes happen in children under 5. Each episode lasts about 3 to 5 days, and it recurs about 4 to 8 weeks. And the fever is associated with either 2 of the 3. I think you can have aphthous ulcers, cervical adenitis, and pharyngitis. Now, it is very important to distinguish these patients from patients who get recurrent streptococcal sore throat. So you need to do throat swab and ASO titers to make sure you're not missing an infection. If it's an infection that needs treating, if it still persists after treating the infection and the streptococcal titers have gone down, that is when you should think about treating it. And It usually, if you look at the natural history, the children usually grow out of it by the time they are in adolescence, but you cannot set a time frame. Some of my patients have grown out when they have been 8 and 9, whereas some others it's gone on till they are 13, 14. The diagnostic criteria are quite non-specific, so you can get high fevers and constitutional symptoms in the absence of upper respiratory tract infection. So if you have a cold and cough, automatically that rules out PFAPA. And obviously you need at least one of the following, that is aphthous ulcers, cervical lymphadenopathy, and pharyngitis. And the patients are completely asymptomatic between episodes. Treatment, the best option once we confirm the diagnosis of PFAPA, which is essentially a clinical diagnosis, is to give a single dose of steroids as soon as the fever starts. And in about 95% of patients, it works. If it doesn't work, you could give a second dose. We usually give 1 milligram per kilogram and ask them to try a second dose either the same evening or the next day. And that usually aborts these episodes. But a slight downside with that is sometimes it can increase the frequency. I've seen patients who have had episodes every 6 weeks. When they started steroids, the episodes became 3 to 4 weeks. But then a single dose of steroid, they don't get any fever or they don't miss school at all. If they continue to have increased frequency, one thing we can try is colchicine, and I'll come to that later. For patients who do not respond to steroids and colchicine, adenotonsillectomy has been advised, and the results on literature vary from 60 to even 100% in some. It's important to realize that increasingly we have been picking up a condition called adult onset PFAPA syndrome. The onset usually in the 3rd or 4th decade, mostly men, and who have a similar episode 3 to 5 years. And this is the new criteria that's been defined for adult PFAPA syndrome, where they have taken away the oral ulcers. Again, the treatment principles are the same. Now we go to the inherited autoinflammatory diseases. I'm not going to talk about this in great detail, just give you a flavor of some of these conditions. So FMF stands for familial Mediterranean fever. TRAPS stands for tumor necrosis factor receptor associated periodic syndrome. HID stands for hyper IgD syndrome, and CAP stands for cryopyrin associated periodic syndrome. So I'm not going to educate you in detail about these conditions. It's important for you to realize that there are a group of monogenic systemic inflammatory diseases which can present as periodic fevers. Now, 2 or 3 things very important for me to know, I take note of is, one is GI symptoms. All these conditions have significant gastrointestinal symptoms, but they can be differentiated by the onset. The only condition where you can get onset in infancy or before 1 year of age is hyper IgD syndrome. The second thing is the duration. So FMF is usually less than 3 years. TRAPS is usually the longest, anywhere between 1 to 2 weeks, and HIDS is roughly about 3 to 7 days. So that's the other thing that helps you make this differentiation. But the most important thing is the complication. FMF and TRAPS can be complicated by, so I've got that wrong. So HIDS is the one where there is no risk of amyloidosis. If you do not diagnose and treat FMF and TRAPS in a timely manner, there is a risk of systemic amyloidosis later on. So as I said, in summarize, FMF, you have short episodes associated with fever, chest pain and abdominal pain, sinusitis, arthralgia, and arthritis. In between is HIDS, which is about 3 to 7 days, where you get splenomegaly. So the only one where you get splenomegaly is usually HIDS. These patients have abdominal symptoms, but they can also have PFAPA-like symptoms with lymphadenopathy and sore throat. TRAPS is the one which you have the longest duration, where you get abdominal pain, chest pain, rash, myalgia, and conjunctivitis. There is a small group of condition called CAPS, cryopyrin-associated periodic syndrome. The one thing we need to remember is this is the only periodic fever which can have onset in neonatal period. And it's important to diagnose and treat it because it can lead to long-term neurological damage and contractures if you don't treat. One classical feature of CAPS group of disorders is urticarial rashes. So when you get high fevers with urticarial rashes, think about CAPS. So how to differentiate between the different conditions? The clinical features, as you can see, are often shared. So I tend to ask 3 questions. One is age of onset. When did it start? If it's less than 1 year, you're only talking about NOMID or HIDS. Duration of attack. If it's less than 3 days, you look at FMF. 3 to 7 days, you look at hits. More than 7 days, you look at traps. And the frequency of episodes. Now, the other important thing is which other system is affected. All these can have abdominal symptoms, but if you get urticarial rashes, you're looking at CAPS. If you're looking at neurological manifestation, you're looking at NOMID. Long-term complications. So these are all complications of the neonatal onset CAPS that I mentioned. You can get neurological problems, sensory neural hearing loss, visual loss, and you can see MSK symptoms like joint contractures and cartilage overgrowth leading to these bony swellings. But the commonest systemic complication is amyloidosis, which is what we tend to prevent. It is important to note that if you do not treat these periodic fevers, as they grow along, the symptoms may actually reduce in frequency. So they think they may have grown out of it, but it's quite possible that the complications like amyloidosis have already set in these patients. The cornerstone of treatment of this condition is IL-1 inhibition. So there are 3 types of IL-1 inhibitors we have. I'm not going to go through in detail. A useful adjunct in treating these conditions is colchicine, but it's very important that we need to use slightly higher dose of colchicine in these patients. If they are less than 5, we use half milligram, 1 milligram if they are more than 5 to 10 years, and 1.5 milligram more than 10 years. So especially FMF patients tolerate these doses quite well. So in short, how do you approach a suspected periodic fever? There is no substitute to good history. You need to go through in detail about the onset, the duration, and the frequency. The other important thing is, I often ask our patients to keep a symptom diary. So, or you can have the calendar at home where you can note down the days when they have that symptoms. And if you look at that, for example, this patient said they're having symptoms lasting 2 to 4 days, which happens every 2 to 3 weeks. So she has underlined the dates. The mother has underlined the dates when he has had the symptoms. And one look at it, we can clearly understand the frequency and the duration of these episodes. So symptom diary is extremely helpful. These are the symptoms I ask for: neurological symptoms like headache and photophobia, eye symptoms, sore throat, mouth ulcers, cervical lymphadenopathy, rashes, abdominal pain, chest pain, joints, and myalgia. So this is like my head to toe symptom inquiry that I do in patients with recurrent fevers. Please remember, these patients can often be completely normal between episodes. So it's important to clinically assess them during an episode. So I usually ask them to come and see us during an episode. Investigations, inflammatory markers are very important. Full blood counts and differential count, ESR, CRP, and ferritin. Obviously, there is a rule that we should be ruling out infection. So I would have a low threshold to do throat swabs and ASO titer in this patient. If you are worried about immunodeficiency, then obviously you need to investigate along those lines. So why is this patient getting recurrent fevers? Is it actually a recurrent infection? That's very important. But one thing to remember is timing of these investigations is very crucial. You need to carry this out during an acute episode. So take home message in periodic fevers: no substitute for good history. Try to get parents to make a symptom diary. It is important for these patients to be reviewed during an episode and investigate during an episode. But infections and immunodeficiency needs to be ruled out before we consider treating these patients. I just a couple of slides about the magnitude of problems in India. So this chart sent by my colleagues in the pediatric rheumatology colleagues in India tells me that these periodic fever syndromes are indeed present in India. But there are some additional challenges in diagnosis and treatment. One is the patients would have been gone to many hospitals, and the awareness of autoinflammatory diseases is not great. And some of these treatments, they may have got recurrent episodes of steroids, which kind of actually can mask the clinical picture. For example, if the TRAPS patient gets recurrent fever, there's recurrent episodes of a recurrent dose of steroids, the fever goes away, but the complications like adhesions and stuff, the peritoneal adhesions and stuff doesn't go away completely. So they end up needing abdominal surgeries. Families may have been told an alternative diagnosis before. There are financial challenges in getting genetic testing done. And the most important challenge is financial support for these treatments, because these are long-term or often lifelong treatment, which are very expensive. And the biggest challenge in India is IL-1 inhibitors are not available in India. Now, I raised this in multiple international forums, but the company that makes anti-albumin have not had come back to me at all with any reason for that. So that in short is my presentation about recurrent fever and persistent fever due to autoinflammatory conditions. If you see patients who you suspect autoinflammatory condition in your practice, please refer the patient to somebody who has got expertise. Always feel free to phone a friend. I'm happy to take a few questions, but again, once again, thank you very much for giving me this opportunity. I'm happy to take a few questions.